Dear all, welcome again to February Grand Round. This is the 2022, and this is going to be my last lecture that I record here from Iraq in Baghdad. And following that, I'll be catching up with you in through our usual meeting, first Friday of the month, when I'm back in Melbourne, Australia. My name is Dr. Ghassan, and today's talk will be about polycystic ovarian syndrome, a paradigm shift. The first update I'd like to share with you is the misnomer title that caused a lot of challenges for us to explain to the patient is about to be changed to reproductive metabolic syndrome, and hopefully we no longer be using the PCOS syndrome anymore. In this talk, we'll discuss the up-to-date guidelines and how to assess and manage RMS, reproductive metabolic syndrome for short, and etiology. By definition, it's a heterogeneous condition. There is a genetic predisposition for it, and it's determined by increasing androgen from both the ovaries and the adrenals. The increase in these production is related to unbalanced gonadotropin secretion, predominantly LH secretion, and relative FSH deficiency relative to the LH. So that's an FSH deficiency relative to the FSH to the LH. Sorry, and this imbalanced secretion of gonadotropins is related to the loss of central negative feedback mechanism, and all that is augmented by insulin resistance. When we talk about RMS, what we look at is we usually treat either issues related to fertility or cosmetic problem or gynecological problem. This is how usually females present to the doctors at different disciplines. But we actually often ignore to address a more important issue, and that is the metabolic syndrome, both diabetes and cardiovascular risk. Again, the etiology is there is, as I just mentioned, is an abnormal GnRH secretion favoring more LH, which stimulates testosterone secretion, and the relative the FSH deficiency relative to the LH levels inhibit the aromatization of testosterone, and this is of course augmented by insulin resistance. So there will be more testosterone secreted and less is cleared. We know now over the last few years, over the last recent years, that there's a loss of paracrine feedback mechanism within the ovaries and the adrenals, and of course there is the central feedback loss mechanism in the neurons. So this is account, but we account for the syndrome, but we don't know actually why this loss of mechanism happens. And in the last recent years, we know that there is the DEN protein encoding gene, which put the patient at risk of familial tendency to develop the syndrome. There's 70% concordance rate in the monozygotic twins, so that's pretty high and pretty significant. Half of the RMS patient will have a sibling with the same condition, and 1/4 of them will have a mother of the same condition. So the familial tendency cannot be ignored in any shape or form. This is a study that looked at the androgen receptors in rodents model, and essentially when they knocked out the androgen receptors in the granulosa cell, the rat developed RMS still. When they knocked out the same receptor in the theca cell and left the granulosa cell, the rat still developed RMS. And when they knocked out the neuron androgen receptors, the rodent did not develop RMS. So it just shows you how show to us how pivotal is the neuron androgen receptors in the whole etiopathogenesis, and where they are located in the arcuate nucleus. In relation to the diagnostic criteria, the old NIH mandate that you have one of these two to confirm diagnosis. The usual, the well-known, famous criteria for RMS, it's either ovulatory dysfunction, predominated by anovulatory cycles, and clinical or biochemical hyperandro. 2003, ultrasound assessment of the ovaries or the sonic features of the ovaries was introduced to this criteria, and that's what we call the Rotterdam criteria. And since then, the numbers of cases were shooted up. The new guidelines suggest it's halfway between these two criteria, where the ultrasound features is only required if you have one of these two and not both of them. So if you have ovulatory dysfunction and a clinical or biochemical hyperandro, you do not need to do ovarian ultrasound. I thought I'll touch base with the different phenotypes of RMS, and the most common, widely known, is the HOPE, which is hyperandrogenism, and O stands for ovulatory dysfunction, and P stands for PCOS. The other condition when you don't have, when you have hyperandro and ovulatory and oligomenorrhea, but normal ultrasound features, and that still qualifies for the diagnosis. On the other hand, hyperandro and normal regular cycles with PCOS on ultrasound. The majority of these cases, albeit are regular cycles, they still have they're actually anovulatory, so the progesterone will be low at 21 onward days. And the last, but not the least important, is when you have oligomenorrhea and polycystic ovary without neither clinical nor biochemical hyperandro. These cases, this category was included because long term they do have subfertility. Now there is now a trend, there is now a theory that's gaining ground that is hyperandrogenism is a prerequisite for the diagnosis. So I think eventually we may well see the OP coming out of this list for the reason I just mentioned. Clinical hyperandrogenism, primarily we're looking at hirsutism with Freeman-Galloway score more than 8, and less significant is the acne and the hair loss, because the androgen levels in the acne and hair loss is a lot lower than those you get with hirsutism, and they're actually non-specific, so you can get acne without any issue of RMS, any other features of RMS, or any evidence of metabolic syndrome, while this is less likely with hirsutism. And what sort of biochemical tests we do? We used to do total testosterone, and we're still doing it, but we don't look at it. We look at the free androgen index, or the free testosterone. Now, we cannot calculate the free testosterone without the total testosterone available. DHEAS is an ancillary finding and reflects the increased sensitivity of the adrenal glands to the ACTH in this condition, but it might drive the physician to investigate the adrenals, so at a cost of patient anxiety and financial um, cost as well. So we'd rather just to do the total T, calculate the free testosterone and look at the free T or the FAI and see how high they are. Bear in mind there's potential for this is what concerns us most, is missing out on the neoplastic hyperandrogenism, which tend to be of new onset and rapid progression with significant biochemical and clinical changes. الحقيقة التستوستيرون يكون بها جدا عالي and voice changes and so forth and so on. The ultrasound features of the PCOS, I thought I'll refresh our memory. When you have essentially what looks into the antral follicles distributed around the periphery of the ovaries, not at the center. And please explain to the patient the misnomer of polycystic, because it's actually not a cystic disease in any shape or form. The transabdominal ultrasound, we only recommend that you look at the ovarian size and don't consider the follicle numbers unless they are above 17. So if the follicle numbers are under 17 in the transabdo ultrasound, this is not significant. And all what you need is look at, when transabdo ultrasound is looking at the size of the ovaries. The PV ultrasound, which is the gold standard, then you need to, again, you look at the size and the follicle numbers. Now with the new advances in the ultrasound features, when you have the ultrasounds more than 4 gigahertz per second, then you will look at more than 17 follicles. The old ultrasound machines, they have a lot less frequencies, and we used to look at the follicle numbers more than 12. And you only need one ovaries that has one of these two features. So one ovary with small follicle numbers but a size of more than 10, you got the diagnosis. Okay, one ovary affected of one of these two features. Now, the indication of ultrasound RMS according to the new guidelines is only when you have one out of the two main criteria of ovulatory dysfunction and hyperandro. You would still need, if you have two of these criteria, you do not need to do it. Fertility, when the other two reasons to consider ultrasound in RMS is if the patient is seeking fertility, because that's part of the fertility workup generally anyway, and if the patient has other gynecological issues. It is not recommended to do ultrasound when you have the two criteria met, as I mentioned, and if the patient is menopausal or she is under the age of 20, because in this age group you will have a high number of follicles anyway. So the new algorithm is, you start, for example, if the patient presents with irregular oligomenorrheic cycles, then you assess for hyperandrogenism. If the latter is not there, then you check the ultrasound. The other way around is true. If someone presented with hyperandro, even with regular cycles, then right at the end you do the ultrasound. So the bottom line is you only leave the ultrasound right at the end here when you have one of the cardinal features absent. This is the diagnostic algorithm of RMS. So stands up here, the highest of the most likely, most important thing to differentiate is the hypothalamic amenorrhea, and I will talk about that briefly in a few seconds. Prolactinoma, hypothyroidism, Cushing, CAH, and pregnancy, of course. It's a battery of tests that will cover all this differential, which we don't know. So in the current guidelines, we suggest that you only do prolactin to rule out prolactinoma. Prolactin can go up in normally can go up in any obese person, but we don't expect it to go up to more than to reach that 2000 cutoff of milli-international ml per liter. So that's less than 90 nanogram per ml. And the TSH, of course, to rule out hypothyroidism, like you do with anyone who comes in with oligomenorrhea. And of course, you might need to check pregnancy if she's sexually active. and the gonadal steroids. And I will take you through the gonadal steroid later on. Now I'll stop at the AMH. anti-malarial hormone I suspect it will have. توقعنا ان ال AMH راح يكون له دور كبير جدا بالمستقبل، وده تلاحظ ان ال AMH بالovulatory RMS is comparable to the control، ولكن بالanovulatory RMS it tend to be very high. The AMH is pivotal in the pathogenesis cascades لأنه it prevents follicular growth and it actually blocks the FSH secretion. احنا قلنا انه ال FSH deficiency relative to the LH is fundamental in the pathogenesis of this condition. This is a study that showed that how the FSH in the normal population level in comparison to the control, while the LH is the opposite picture. It's low in the control and much higher in the PCOS patient or RMS patient. The AMH inhibits the CYP19 gene, and this gene inhibit the aromatase enzyme and subsequently inhibit, and the aromatization is critical in the FSH receptor presentation. So eventually what you have is less FSH secreted and less FSH receptors in the ovaries. So this both biological deficiency in the FSH relative to the LH, and also less efficient functional deficiency, I would say as well. The AMH, when it's elevated, it has almost 100% sensitivity area under the curve. So that's the specificity and the sensitivity of the AMH is higher than that of the Rotterdam criteria. Now, please bear in mind the specificity is 100%. So when it's elevated with someone who had hyperandral and oligomenorrhea, the diagnosis is 100% accurate. ولكن مشاكل AMH لها أول ما لها آخر. It's a not standardized test, and it has a lot of caveats in terms of sample handling and processing, and there's a lot of intra and inter-individual variation, and there's a lot of external factors that affect the result, including the pills, which reduce the AMH, and the vitamin D level supplement, which increases the AMH. So unfortunately the AMH has no practical role at this stage as yet. But once we get all these, particularly the standardization of the test, then we will be able to include it in the criteria. Currently, the way we check the AMH is through RIA, and this is not a reliable test for this particular hormone. So the update is in terms of the biochemistry. Please do check prolactin and TSH. This need to be done routinely for every single RMS patient, and of course you need to check the lipid profile and the glucose tolerance test, and we recommend that you do that every 2 years because they are at high risk of developing diabetes or pre-diabetes at least. We do need to check the gonadal steroid, and I'll take you through why. And selectively, you need to check for 1 milligram DEXA suppression for those who you suspect Cushing's, follicular 17 OHP if you suspect CAH, and DHEAS if you suspect adrenal malignancy in cases of a new onset rapid progression of clinical hyperandrogenism. Now, why do we check for gonadal steroid? Because if you have high FSH and low estradiol, then particularly high, by that I mean more than 25, then you're probably dealing with a premature ovarian insufficiency. If you have the whole panel is low, then you're dealing with hypothalamic amenorrhea. LH and testosterone, or testosterone measurement need to be done in females and hand in hand alongside the LH, because in the luteal phase, when the LH is high, during ovulation, for example, the testosterone will be very high as well. So you need to make sure that the LH is not shooting up and driving the testosterone to go up as well. Hypothalamic amenorrhea, when you have the whole gonadal panel reduced, is a fairly common in the differential, probably high on the highest now. Now we know that hypothalamic amenorrhea is not all, it's related to reduced caloric intake or imbalanced calorie daily intakes in females, which doesn't need to be associated with increased vigorous exercise, but more commonly associated with severe depression. Now, and a lot of females with functional hypothalamic amenorrhea, or FHA, are actually, a lot of them actually have normal BMI. They just recently stopped eating and they developed the condition. So, I thought the differential is important to note that there will be increased number of antral follicles in FHA, but they are distributed across the ovaries. The LH is reduced, as you would expect. And at the end of the day, if you're in doubt, then you do need to do progesterone challenge tests, where you give the Provera for 10 milligram for 10 days, and then you wait for the bleed to happen, or withdrawal bleed to happen, if at the end of the month. And if that will be consistent with RMS. If the patient did not have the withdrawal bleed, then this will confirm the diagnosis of functional hypothalamic amenorrhea. This is a study here that showed about almost 50% of patients with FHA actually have RMS, and once you treat FHA, the RMS will be revealed. How to differentiate? So that's actually quite confusing, but the message to take home: the two conditions can coexist together and can be separate, and they have a different biochemical pathogenic profile. So the LH tend to be high in RMS and low in FHA. SHBG is low in RMS, what's normal or high in FHA. Androgen are elevated clearly, while in FHA it's a state of hypogonadism, and therefore the androgen will be low. And the follicles on the ultrasound can be peripherally distributed, and while in the FHA is equally distributed. So why it's important? I think it's critically important because the management is exactly the opposite. In RMS, you need to cut down on the calories, while in FHA you need to encourage the patient to increase the daily calorie intake. So, it's clearly a mirror image of management. I'll move on to the issue of lean RMS. And I picked up this study. It showed that more than 75% of patients, when they do with the lean RMS, once you do clamping, it demonstrated that the lean RMS has same level of insulin resistance, or even higher than the obese control. In this study, they used I think it was the WHO clamping criteria. If you use a different criteria, you might end up with more than 75% having insulin resistance. Another study here that showed the percentage of RMS has a long linear relationship with the BMI, but this is not always the case, because there's still a percentage of people who have, almost 1/3, who have RMS with a normal BMI or a slightly increased BMI. This is the message to take home. A substantial percentage of patients with RMS are of normal BMI, but they are still insulin resistant, and we do know from different studies that the central adiposity is increased in this condition anyway, in lean RMS, in this subgroup of patients. Moving on to RMS in adolescents, it's going to be difficult to distinguish from the normal physiological maturing process of the hypothalamic gonadal axis, or hypothalamic pituitary gonadal axis. It takes about, on average, 2 years, and this is a study showed that about 80% of females are or girls are have anovulatory cycle in the first 1 year, 60% anovulatory in the second year, and after 6 years, there's still about 20% having irregular anovulation. So you need to take your time in this group and bear in mind it might be more than 2 years actually for the period to become regular. Adrenal androgen tend to go up in this group, and the ultrasound in this age group normally showed multiple increased number of antral follicles. And please bear in mind that you might need to check the 17-OHP follicular phase if you have a high-risk patient for CAH, or anything in the history suggestive of CAH in the high-risk ethnic group مثل العراقيين. فهي مثل هذه الحالات يعني I always ask the patient if the child was taller than her peers and become shorter than her pre-caucity and become shorter than her peers when she went through puberty. So it's important to differentiate because it has a critical long-term, lifelong ramification, and management are quite different in both conditions. Treatment goals, we'll move on to treatment goals, and it's either cosmetic or whether it's metabolic or fertility issues. Cosmetic management, lifestyle modification and laser therapy does the job. It works, and it works well. OCP, again, it's effective and works well, and spironolactone, less effective, and finasteride, which I don't usually prescribe because of concerns of long-term adverse effect on libido and sexual dysfunction. It's well established the sexual dysfunction of finasteride long-term in men, but it's in female is still controversial, with some studies suggested that it's actually safe. Finasteride causes quite a bit of derangement in the sex steroid long-term, and it's well known now to cause lifelong reduced libido in men. I don't think we need to prescribe metformin for hirsutism because it doesn't work. And again, anti-androgen pills, I hardly consider it. One of the reasons is because we think that there's increased risk of aromatization of testo to dihydrotesto in the follicles roots, as opposed to in the systematic, in the plasma, and these anti-androgen doesn't work well on different receptors in hair follicles, so it's very doubtful if benefit. And all what the patient need to do to improve their alopecia or hirsutism is just simply try to lose some weight. So weight loss is pivotal in diagnosis, and deep laser therapy is very effective. OCP, and I have to say you don't need to use high estrogen OCP, just the usual dose. Spironolactone, it works, but you need about 100 milligrams once a day. You don't need to give more than 100, and please monitor the potassium, and don't forget to give OCP if the patient alongside spironolactone, because it's teratogenic if the patient is sexually active. Again, finasteride, as I mentioned, is of doubtful benefit. OCP, the way it works, it increases SHBG and reduces GnRH, so it works well. It needs to be estrogen based. So progesterone alone, OCP doesn't work. You need to wait for a good 6 months often to show benefit, and no need for high estrogen pills. This is important. And again, the progesterone is of limited value, and you don't need anti-androgen progesterone because of the increased risk of DVT. You truly don't need that. This is a study in relation to the metabolic profile. It shows that increased VEGF in the RMS population in comparison to the group. So this is a biomarker of increased risk of cardiovascular events. Another study that showed the benefit you get in metabolic profile once the patient lose weight through different agents, liraglutide, metformin, or both of them together, orlistat, so forth and so on. Weight loss in any shape or form is helpful in restoring ovulation and improving the metabolic profile indices. بما فيها bariatric surgery, لكنه the study was limited on 17 patients or thereabout, and they were not which should resume their regular cycle once they lost weight, as we expect. But that study did not include the weight loss, the RMS biochem as an endpoint. ولكن and we don't يعني حقيقة consider RMS as an indication for bariatric surgery at this point in time. So weight loss program is important, and metformin, it works well. Metformin without it doesn't, it's not a weight losing agent, but it reduces the incidence of weight gain in this group of patients. Metformin works as well in regulating the periods. It does help through reducing insulin resistance. It's actually effective in restoring period regularity in this group. So I have a low threshold to prescribe metformin, even if the patient have normal glucose tolerance test. I'll take this case of a 27-year-old nulliparous who is seeking fertility with oligomenorrhea, and her practitioner referred her to my practice with a query RMS. She had a temporal weight gain of 7 kilograms. She had a menarche at the age of 12, had regular cycles prior to the last 2 years, and once she gained that weight, her cycles become irregular and infrequent. And she had positive family history of RMS. The patient, she was normotensive. She had hirsutism with a Galloway score of 9. She had no other stigmata of Cushing disease, and she was clinically thyroid. Her gonadal steroid panel is consistent with the typical for RMS. Prolactin was normal, TSH was normal, she was anovulatory, her total T was normal, the free testosterone was elevated, sex hormone SHBG was low. I don't think we needed to do the androstenedione, DHEA, and 17-OHP. I don't think that was necessary. I did two fortnightly cycle tracking, and again showed a consistently anovulatory cycle with consistently undetectably low progesterone. What else you like to do? I guess you have to do the glucose tolerance test, and please bear in mind that the HbA1c has no role in the diagnosis in RMS, because if it's marginally normal or marginally elevated, it can be easily false. إذا كانت الزيادة أو النقصان عن الحد الطبيعي شوية بسيط 6.4 or 6.3 أو 6.8 مثلا. So please consider OGTT in this group of patients. Weight loss, moving on to the impact of weight loss and fertility issues. So this study showed that the rate of pregnancy rate was 20% in lifestyle modification, which is even higher than those of clomiphene and metformin. So losing 5 to 10% of the patient weight will promote will have the advantage of about 80% success rate in regulating the period, restoring the periods in females. So it just shows you how important the weight loss is, and they don't need to lose that much weight anyway. Metformin and clomiphene, in terms of rate of live birth, the combination is better than either drug alone. This is the message to take home. We give clomiphene starting from day 5 for 5 days, a cycle of 5 times. Please bear in mind that the risk of multiple pregnancies in this group, and you might need a touch of HCG single dose once the follicle is 20 millimole to establish ovulation. Letrozole is gaining ground against clomiphene. It's as effective as clomiphene in the overweight patient, but once the BMI hits 30 plus, the letrozole become a lot more effective than clomiphene. Pre-IVF, I think again, it is a summary of what I've just mentioned. Is please consider, please enroll your patient in lifestyle modification. Start with metformin, even if the patient have normal glucose tolerance, to restore cycle regularity. And the rest is as mentioned. Then you could consider repeated cycle before you move to IVF. This group of patients are actually very high risk group in IVF because they are at much higher risk of multiple pregnancies and or ovarian hyperstimulation syndrome. They need a very small dose of FSH. Fertility issues is, as I said, it's one of the patient drive to our clinic, and again, you only need to have weight loss of 10% to restore fertility in substantial number of patients, about 80% of them. If they lose 10% of their weight, they'll become fertile. And finally, the summary of my clinical approach to fertility is I tend to prescribe OCP for 3 to 6 months alongside lifestyle modification. The whole idea is to reduce the level of androgen before we start the clomiphene or the letrozole. And if that's failed, then yes, I will move to IVF. Unless if the patient age doesn't give you that window of multiple trials. Practice point in relation to lean RMS, as I said, 1/3 of the group are actually lean, but they still have increased visceral adiposity. They have higher insulin resistance. They are more insulin resistant than obese non-RMS, and they are just as subfertile as the obese RMS. And how you treat them, you can't tell them to lose weight because they're already lean, but you can tell them to reduce the high calorie intake. And finally, the new kid on the block, I'll take you through the androgen pathways. That historically we look at the testosterone and dihydrotestosterone as the culprit in this syndrome. However, recent novel pathway found is the androstenedione get hydroxylated in the 11-hydroxyandrostenedione. Now, we knew that for decades, but we thought this is a rubbish byproduct. Until recently, a group from Geneva, they looked at this substrate and turned out to be, or this byproduct, and it turned out to be it's become a substrate for formation of further hydroxylation, forming ketotestosterone from ketoandrostenedione to ketotestosterone, and this is as effective in stimulating the androgen receptor, peripheral androgen receptors, as effective as the dihydrotestosterone. So we did not know that this byproduct will become a substrate for further hydroxylation until recently. This is a study showed here that the 11-keto-T is in RMS patient is 2-3 times than that of the control. And the surprise is here that even in the control female, the ketotestosterone is twice that of men anyway. In another way, in RMS patient, the steroid, the oxygenated androgen often, the oxygenated androgen depicted here by the red colors, shades of the red colors, are the predominant androgens in the serum of these patients, and they still represent a good percentage of total testosterone even in the controls, because normally what I'm trying to say is that these hormones, the oxygenated steroids, are the predominant. Often the oxygenated androgen are the predominant androgen in females anyway, and they go much higher when the patient had RMS. So this is the message. Another message to take home: the biomarker of hyperandrogenism in female will be the oxygenated androgen. This will be quite useful in diagnosis RMS and CAH. Elevated AMH is highly specific for RMS, but it's not a reliable assay, and ovarian ultrasound is not a prerequisite for the diagnosis. Projection for future: I think the RMS will require elevated ketotestosterone, RMS diagnosis in the future. We just need to measure the keto T. We don't need to measure the free T, أو يعني لا total T ولا حتى الفري تي، لأنه هاي ممكن تكون طبيعية بهاي الحالات. اللي يرتفع فعلا هو الكيتو تستوستيرون. فإذا عندك elevated keto T and elevated AMH, then you got the diagnosis. طبعا in the right context, the right group of patient. And the issue of having regular periods or irregular periods will be taken out of the diagnosis. لأنه we really feel that there's a strong suggestion that the hyperandrogenism is a prerequisite for the diagnosis. من غيرها ما تقدر تسوي. Hyperandrogenism, both either chemical or bio or clinical, is a prerequisite. You need that. So you get that first, and then you check the keto T, and then you check the AMH, and you got the diagnosis. And there will be no role for ultrasound, ovarian ultrasound in the future, I'm sure. I'll stop at this point, and I thank you all for for attending the seminar, and both virtually and hopefully in real time when we presented it in February. Thank you all. Take care.